Good morning, and thank you for the invitation to speak to you today. My name is Dr. Kathleen Motil. I'm from Baylor College of Medicine in Houston, Texas. The title of my presentation is Gastrointestinal Myths and Misconceptions in Rett Syndrome. I want to disclose that I'm a consultant for Acadia, the company that sponsored trofinetide. I have no financial relationships with manufacturers of commercial products. I will not discuss the unapproved use of commercial products, and the International Rett Syndrome Foundation has provided funding for my Rett-related research activities. The objectives of my talk are: 1, to highlight the clinical features of two common gastrointestinal problems in Rett: feeding difficulty and constipation, and the second, to describe treatment approaches to feeding difficulty and constipation. Parents often have misconceptions about feeding problems and bowel habits in their children with Rett. My daughter has a great appetite. She eats all the time, but she doesn't gain weight. My daughter won't go to the bathroom unless I give her something to make her go. I don't want her to become addicted. These are often two common concerns that I hear about the girls with Rett syndrome. It's important to know that gastrointestinal symptoms complicate the clinical course and quality of life of individuals with Rett throughout the Rett lifespan. Gastrointestinal problems pose substantial medical burdens for the caregivers of individuals with Rett, and the gastrointestinal manifestations may be more debilitating than the underlying neurological features of Rett. Parents often say, "My daughter has a good appetite. She eats a lot." However, girls with Rett syndrome have feeding difficulty. Girls with Rett have a prolonged feeding time, taking approximately 30 to 60 minutes to finish a meal. They have decreased oral efficiency due to chewing and swallowing dysfunction. Oral dysfunction leads to decreased dietary and energy and nutrient intakes. And decreased dietary intake leads to poor weight gain. We can evaluate feeding difficulty by a visual feeding study. We ask about coughing or choking when drinking fluids or eating food, and we ask about increased drooling, both of which indicate difficulty swallowing. We can evaluate feeding difficulty with the swallow function study, which is a radiographic study shown here in this slide. We will evaluate poor jaw movement, poor tongue lateralization, poor food propulsion, pulling of fluids or food in the throat, delayed initiation of the swallow reflex, or laryngeal penetration and tracheal aspiration of fluids and food. Therapy to improve oral feeding skills is limited. We focus on postural alignment, oral desensitization, jaw stabilization, and tongue organization. No loss of function is good progress. We can thicken liquids to facilitate swallowing. We use finely chopped or pureed foods to facilitate chewing. Appetite stimulants are generally not useful. There is no apparent benefit with VitalStim, a device that is used to stimulate swallowing. And we encourage parents to learn cardiopulmonary resuscitation, CPR, in the event of aspiration. Abnormal growth, shown in the blue lines on this slide, is a pervasive problem in Rett. Weight deviation begins as early as 6 months of age. Length deviation occurs by 17 months of age. The pubertal increase in height and weight is absent in Rett. Poor growth is associated with greater developmental delay and higher disease severity. The growth abnormalities are due in part to poor nutrition. The body mass index, or the BMI, is the standard method to assess nutritional status in Rett syndrome. Body mass index is the ratio of weight to height or length. The BMI for prepubertal Rett girls, when normal, is between the 25th and 50th percentile. And for the postpubertal Rett girls, normal is between the 5th and 25th percentile. We consider alternative feeding methods if the BMI is less than the 5th percentile or off the graph as shown in this particular slide. Energy imbalance accounts in part for growth abnormalities in Rett. Dietary energy consumption is approximately 30% lower in Rett than in unaffected girls. Total daily energy expenditure and sleeping metabolic rates are approximately 15% lower in Rett than in unaffected individuals. Energy expenditure associated with physical activity is reduced in Rett, and there is no evidence of energy losses by malabsorption in Rett. Treatment approaches to feeding difficulty include oral supplements of blenderized food and formulas or gastrostomy button placement. Dietary energy needs for catch-up growth are approximately 130 to 140% of the resting metabolic rate. The indications for gastrostomy button placement include a BMI persistently falling less than the 5th percentile for more than 6 months, significant chewing and swallowing dysfunction with or without aspiration, or parental request for feeding refusal. Constipation is defined as difficult defecation with straining during stool elimination. Bowel movements are usually less than 2 times per week, and stool consistency is hard, small pebbles, or large ball size. Blood may be seen on the stool. The cause of constipation is probably multifactorial and includes abnormal nerve muscle function and dysbiosis of the gut microbiome. Complications of constipation include anal fissures and fecal impactions. Adverse outcomes of constipation include abdominal pain, feeding refusal, urinary tract infections, and increased frequency of seizures. This slide illustrates the differences in intestinal neurotransmitters in the enteric nervous system in Rett syndrome. Intestinal neurotransmitters such as nitric oxide is expressed in greater amounts in Rett, shown in the top slide, than in control cases shown in the bottom slide. This observation supports the concept that there is dysregulation of nerve function in the girls with Rett syndrome. This slide illustrates differences in the gut microbiome in Rett based on clinical severity. Mild to moderate clinical severity is shown on the left panel, and severe clinical severity is shown on the right panel. The relative abundance of bifidobacterium, a type of bacteria, is higher than the relative abundance of Faecobacterium in more severely affected than in less severely affected girls. This This slide and this difference supports the concept that dysbiosis of the gut microbiome contributes to intestinal dysfunction in Rett syndrome. This slide illustrates the differences in the gut bacterial metabolome in Rett, shown in red on the slide, and unaffected girls, shown in blue on the slide. The fecal concentration of two neurotransmitters, gamma-aminobutyric acid and glutamate, are lower in Rett than in unaffected girls. The fecal concentrations of two neurotransmitter precursors, tyrosine and tryptophan, are lower in Rett than in unaffected girls. This observation supports the concept that alterations in the gut metabolome contribute to intestinal dysfunction in Rett. The assessment of constipation includes an abdominal and rectal exam. We may obtain an abdominal X-ray to look for large amounts of impacted stool in the rectal vault, shown here in this slide. We may obtain a barium enema to look for a redundant colon. Parents often say, "I want something natural to treat constipation," but natural options usually are not enough in Rett syndrome. Dietary fiber in fruits, vegetables, and cereals may be helpful. Fruits that contain sorbitol, such as prunes or pears, may also be helpful. Prebiotics, such as psyllium or flaxseed, may be helpful. Probiotics that contain Lactobacillus rhamnosus, Lactobacillus reuteri, or Bifidobacterium may be helpful. But parents need to beware of herbals that contain licorice, because licorice may aggravate the prolonged QTc abnormality in Rett syndrome. Medications that soften, push, and pull, individually or in combination, are used to treat constipation. However, softeners such as polyethylene glycol, lactulose, and mineral oil are slow to act, require frequent dosing, and may produce gas. Pushers such as milk of magnesia and senicides have dosing limits to avoid side effects. Pullers such as glycerin, bisacodyl, or docusate suppositories are useful and used with increasing frequency as age increases. The surgical approach to constipation includes cecostomy button placement or colonic resection for colonic redundancy or atony. And finally, physical activity such as walking, standing, or physical therapy should be encouraged. In summary, feeding difficulty and constipation are the two most common gastrointestinal problems in Rett. Despite parental fears and frustrations, treatment strategies for feeding and constipation improve the quality of life of individuals with Rett. Thank you.